This is going to be a rhythm review, and for treatment, recommend reviewing this information before coming to class. Starting with the P wave, 0.4 to 0.10 seconds, PR interval 0.12 to 0.20 seconds, QRS 0.06 to 0.10 seconds, QT interval less than 0.40 seconds, T wave 0.10 to 0.25 seconds or greater. The U wave is normally not determined unless it's abnormally tall, but it could mean hypokalemia, cardiomyopathies, or it could happen after a patient received digitalis or quinidine. Now don't confuse that the tall peak T waves could be hyperkalemia. The P wave represents depolarization of the atria. So atria depolarization leading to atrial contraction. PR interval represents the depolarization of the atria, the atrioventricular node, the bundle of His, bundle branches, and the Purkinje fibers. The QRS interval represents ventricular depolarization leading to ventricular contraction. The normal QRS interval is 0.06 to 0.10 seconds. Then if a patient's QRS interval is 0.14 seconds, could indicate that the conduction through the ventricular system is prolonged. The ST segment represents the time between ventricular depolarization and repolarization. It should be flat or isoelectric, and it represents the absence of any electrical activity. The T wave represents repolarization of the ventricles. The QT interval represents the total time for depolarization and repolarization of the ventricles. The Q wave is the first negative deflection following the P wave and should be narrow and short. And the Q waves often develop with the ST segment elevation MI. Leads 2, 3, and AVF reflect the inferior area of the heart, the ST segment changes, and mitral regurgitation. Lead 2 will best capture any electrocardiographic changes that indicate further damage to the myocardium. V3 and V4 are associated with cardiogenic shock. This is normal sinus rhythm. The S1 signifies the onset of ventricular systole. S2 signifies the onset of diastole. This is sinus bradycardia. If a patient has sinus tachycardia, they may have multiple etiologies such as pain, dehydration, anxiety, and myocardial ischemia. Further assessment is needed before determining the treatment. Now, vagal stimulation or beta blocker may be used after further assessment of the patient. Electrical cardioversion is used for some tachydysrhythmias, but it is not used for sinus tachycardia unless the patient is symptomatic. This rhythm is atrial fibrillation. This rhythm is showing atrial flutter. The top left is bigeminal premature ventricular contractions. A ventricular bigeminy describes a rhythm in which every other QRS complex is wide and bizarre looking. The top right is a trigeminal premature ventricular contraction because every third beat is a premature ventricular contraction. Now, pairs of wide QRS complexes are described as ventricular couplets, and stress can bring about occasional premature ventricular contractions in a person as well as overuse of caffeine. In a patient with a normal heart, occasional premature ventricular contractions are a benign finding. So again, this particular rhythm is showing a couplet. This rhythm is asystole. Ventricular tachycardia is the absence of P waves, a wide QRS, a rate greater than 150 beats per minute, and the regularity of the rhythm indicate ventricular tachycardia. Now this is different from sinus tachycardia because sinus tach has P waves. The burst of sustained ventricular tachycardia indicates that the patient has significant ventricular irritability, and antidysrhythmic medication administration is needed to prevent further episodes. If the patient has an implantable cardioverter defibrillator that keeps firing, then it may indicate that the patient's ventricles are very irritable. and the priority then is to assess the patient, administer ordered medication such as amiodarone, lidocaine, or mag sulfate. This rhythm is supraventricular tachycardia. This rhythm is ventricular fibrillation, and this is irregular and does not have a consistent QRS duration. The bottom rhythm starts as VTach and then goes to VFib. Remember that a defibrillator can be used for VTach and VFib. First degree atrioventricular block is asymptomatic and requires ongoing monitoring because it may progress to more serious forms of heart block. The rate is normal, so there's no indication that atropine is needed. Second degree heart block type 1, Mobitz 1, or Winkie-Bach, is an electrical conduction system problem of the heart in which the PR interval has progressive prolongation until finally the atrial impulse is completely blocked and does not produce a QRS electrical impulse. Once the P wave is blocked and no QRS is generated, the cycle begins again with the prolongation of the PR interval. Second degree AV block type 2 is almost always a disease of the distal conduction system located in the ventricular portion of the myocardium. Second degree AV block type 2 is clinically significant for ACLS because this rhythm can rapidly progress to complete heart block. Once it progresses, then it may need to be treated with immediate transcutaneous pacing or transvenous pacing because there is a risk that electrical impulses will not be able to reach the ventricles and produce ventricular contractions. Third degree heart block or complete heart block occurs when the electrical impulse generated in the SA node in the atrium is not conducted to the ventricles. The inconsistency between the atrial and ventricular rates and the variable PR interval indicate that the rhythm is a third degree AV block. When the atrial impulse is blocked, an accessory pacemaker in the ventricles will typically activate a ventricular contraction. This accessory pacemaker impulse is called an escape rhythm. The PR interval will appear variable because there is no relationship between the P waves and the QRS complexes. Any waveform without a pulse is pulseless electrical activity. The PEA rhythm occurs when any heart rhythm that is observed on the ECG does not produce a pulse. PEA usually has an underlying treatable cause, and the most common cause in emergency situations is hypovolemia. Cardioversion is a synchronized circuit that delivers a countershock on the R wave of the QRS complex of the ECG. The synchronizer switch must be turned on. The cardioversion may be done after several weeks of anticoagulation therapy. When a patient has a non-emergency cardioversion, sedation is used just before the procedure. Defibrillation is the most effective method of terminating ventricular fibrillation and pulseless ventricular tachycardia. Passage of DC electrical shock through the heart to depolarize the cells of the myocardium allow the SA node to resume the role of the pacemaker. If the patient's rhythm and assessment indicate ventricular fibrillation and cardiac arrest, the initial action should be to defibrillate. The insertion of an intracaval filter that partially occludes the inferior vena cava will trap emboli to prevent a pulmonary emboli traveling to the lung. Ligation is suturing or placing clips on the inferior vena cava to prevent a pulmonary emboli. Preoperative interventions for a vena cava filter is that if the patient has been taking anticoagulants, they need to consult with their healthcare provider regarding discontinuation of the medication to prevent hemorrhage prior to surgery. Now, after surgery, the patient would be instructed about using anticoagulant therapy and the hazards associated with those medications. All circulatory assist devices decrease ventricular workload, increase myocardial perfusion, and augment circulation. Examples include intra-aortic balloon pump and left or right ventricular assist devices. These decrease the cardiac work and improve organ perfusion when drug therapy fails. The intra-aortic balloon pump provides temporary circulatory assistance, decreases afterload, and augments aortic diastolic pressure. The outcomes is that it would improve coronary blood flow and improve perfusion of the vital organs. During systole, the balloon is deflated, which facilitates ejection of the blood into the periphery. In early diastole, the balloon begins to inflate. In late diastole, the balloon is totally inflated, which augments aortic pressure and increases the coronary perfusion pressure with the end result of increased coronary and cerebral blood flow. The intra-aortic balloon pump consists of a pump that inflates and deflates a balloon. A control panel for synchronizing balloon inflation is noted with the cardiac cycle. The balloon is inserted percutaneously or surgically into the femoral artery. It is advanced toward the heart and positioned in the descending thoracic aorta just below the left subclavian artery and above the renal arteries. The action of the balloon pump can also cause physical destruction of platelets and thrombocytopenia. Peripheral nerve damage can occur, particularly when a cut down is performed for insertion. Patients receiving intra-aortic balloon pump therapy are prone to infections. Complications of the intra-aortic balloon pump include mechanical complications, improper timing of the balloon inflation, increased afterload, decreased cardiac output, myocardial ischemia, and increased myocardial oxygen demand. Mechanical complications are rare, but they do occur. If the balloon develops a leak, the pump will automatically stop. Signs of a leak include less effective augmentation, repeating alarms for gas loss, and blood backing up into the catheter. To decrease the risk of intra-aortic balloon pump therapy, obtain cardiovascular, neurovascular, and hemodynamic assessments every 15 to 60 minutes based on the patient's status. Keep the patient immobile and limit them to side-lying or supine position with head of the bed less than 45 degrees. The leg with the intra-aortic balloon pump catheter must not be flexed at the hip to avoid kinking or dislodgement of the catheter. A ventricular assist device provides interim support when the left, right, or both ventricles require support while recovering from injury, such as a myocardial infarction, or the heart requires surgical repair and the patient must be stabilized, such as a ruptured septum, or if the heart has failed and the patient needs cardiac transplant. A ventricular assist device provides short and long-term support for the failing heart. It does allow greater mobility than intra-aortic balloon pump. It is inserted into the path of flowing blood to augment or replace action of the ventricle. Ventricular assist devices can be implanted in the peritoneum or positioned externally and provide biventricular support. A typical ventricular assist device shunts blood from the left atrium or ventricle to the device and then to the aorta. Indications for ventricular assist device therapy is extension of the cardiopulmonary bypass, failure to wean, post-cardiotomy cardiogenic shock, bridge to recovery or cardiac transplant, and patients with the New York Heart Association Classification 4 who have failed medical therapy. A patient with a pacemaker should be instructed to avoid lifting their arm on their pacemaker side above the shoulder to avoid displacing the pacemaker leads. The patient should notify airport security about the presence of a pacemaker before going through the metal detector and should not be around vibrating machinery. Preparation for discharge is complex and requires in-depth teaching about the device and support equipment, like battery chargers. Observe the patient for bleeding, cardiac tamponade, ventricular failure, infection, dysrhythmias, renal failure, hemolysis, and thromboembolism. The patient may be mobile and will require an activity plan. And patients must have a competent caregiver present at all times. The goals for ventricular assist device patients is recovery through ventricular improvement, heart transplant, or artificial heart implantation. Many patients will die or choose to terminate device causing death, and psychological support for patient and the caregiver is essential.